Good afternoon, everyone, and thanks for joining. If I can ask you guys to please mute your phones or computers if you're not the one speaking. I'm going to kick us off here, and then Dr. Banagas is going to introduce our speaker for the day. My name is Awi Madakam, the Medical Director for the Division of Public Health. And this is the Hot Topic CME, which was started a few years ago under the excellent leadership of Dr. Stephen Kushner. And so the Health Equity Institute has been partnering with the Medical Society to provide these lectures so that everyone is up to speed on the latest and the best as relates to healthcare and public health, particularly health equity. So I will turn it over now to Dr. Banagas, who will be introducing our speaker of the day.
Well, hello, and we're pleased to welcome Nicholas R. Conte Jr. He's a orthodontist who has spent 25 years in dentistry, working in a variety of roles spanning private practice, academia, industry, and public health. Dr. Conte has earned a BA from the University of Rochester in New York in health economics and completed both his DMD degree and his prosthodontic residency program at the University of Medicine and Dentistry of New Jersey. Now, Rutgers School of Dental Medicine, in Newark, New Jersey. In addition, Nick earned an MBA from Wilmington University in Delaware. Nick serves as a dental director for the Bureau of Oral Health and Dental Science Services, Delaware Division of Public Health. So, take it away.
Great, thanks so much. And good afternoon to all of you. Thank you to Dr. Maduka, Dr. Banagas for the introduction and the invite to speak to you all today. And thank you guys for your time. I realize we're in the middle of a work day, and I appreciate you taking some time out. Hopefully I'll provide some valuable information and spark some interest in a pretty important topic to me. So I've titled our talk Dental 101 for the Primary Care Physician, a look at the relationship between oral and systemic health. But in truth, we're going to take a look at just even a little bit more than that today. So when we look at oral health, we'll talk about what constitutes good oral health. What are some of the considerations on both a national and state level when it comes to health equity and to oral health equity in particular? And to help us kind of frame the conversation for when we get to the part about oral and systemic connections, that we can start to take what we already know and understand about our population, about our state, and about what's going on around the country, and make that applicable to our own practices. We'll talk a bit about medical and dental collaboration. As you see in my first slide, I've got this kind of split path or split direction. And I think one of the things, as I've been a professional now more than 25 years, that I've been disappointed with is how separated medicine and dentistry have always been. And we could probably spend the entire hour talking about just that. But the reality is we're far better when we work together. Our patients receive far better care when we collaborate. So we'll touch on that a bit as well. And then we'll talk about some oral and dental conditions that you might identify if you are in the office, are doing screenings, are having conversations with your patients, and kind of wrap it up with some ways that we could provide guidance or things we can integrate into our everyday conversations that could have an important impact on our patients prioritizing and receiving oral health care. So I'll start out and just say that oral health should be defined as not just the absence of disease, but the presence of oral wellness. And what that really means is that when we have healthy teeth, gums, a tongue that allows us to speak, chew, enjoy our food, smile, all of that, it's really just, it's beyond just our teeth, but really includes everything that is connected in and to around our face. And that oral health is also being free of mouth and facial pain, right? Oral and throat cancer, oral infection and sores, periodontal disease. And that'll be a focus for us for several minutes during the conversation to really understand what a huge impact periodontal disease has on our patients and how prevalent it is in our country today. And also that idea, again, that any of these, any disorder or any form of dental decay might really limit an individual's ability to bite, chew, to eat and enjoy their food, right? To smile, to speak, and even their psychosocial well-being. So a lot to consider, right? It's not just teeth. And we also recognize that oral wellness can have direct impact on our enjoyment, like we just said, eating and drinking, but really beyond that on things like obtaining a job. And I can't tell you how many times, and I was introduced as a prosthodontist. If you guys aren't aware, a prosthodontist is basically a rehabilitative dentist. So we take kind of patients with advanced oral care needs and we rehabilitate our patients. And I can't tell you how many times I've heard patients say, I really want to get my teeth fixed so I can go after that job, right? I'm embarrassed of the way I look. And that leads to that third piece there is that confidence in social interactions. One sad part I heard throughout the pandemic a few years back was people saying, I didn't really mind having a mask on because it hid what was going on in my mouth. And we really shouldn't live that way, right? We should understand that teeth shouldn't hurt or limit us. It should only contribute positively to our existence. And we recognize that oral pain can be linked to poor school performance in children. And that's one of the things my group is very focused on. So each year we see statistics about how many hours of school are missed, how many days of school are missed. But the reality is we all understand that children learn better when they're pain-free and they're focused on their education. And we all want our schools to perform well. And part of that is having healthy children in our schools. We also talk and see statistics nationally about the work loss, right? What that means to us when we have oral pain and we can't go to work, whether that limits ourselves or our children. Oral pain, again, is linked to difficulty in chewing, inadequate nutrition, eating things like steak or apples, right? Which then make that whole nutrition piece harder and harder to keep up with. And something we're very focused on in our state is this idea of costly emergency department visits. And while the pandemic a few years back gave us some things we'd like to leave behind and forget, the truth is one thing it did for us is it brought the importance of oral health into focus. And dentists were serving as frontline defenders for you all, right? Making sure that we didn't take up emergency room time, physician visit time, things that could otherwise be costly to us as a profession and as a society. And unfortunately, dental often gets left behind, right? When we talk about health, we think medical health predominantly. But in 2000, we first saw a Surgeon's General report in our country that included dental. And recently in 2021 had that updated. But some of the highlights of that, if you're not familiar, is this idea that dental care is the most common unmet health need, and that we recognize that oral health adversely affects systemic health. Now, we should also be familiar with the idea that most oral disease is preventable or at least manageable, right? Once that bacterial transmission has happened, it's very difficult to ever rid us entirely of that bacteria, but certainly we can manage that. We can control some of the causative factors that lead to disease. And we really need to be focused on that as a combined group, right, of medical and dental professionals. But certainly there are profound disparities that exist for all ages, and we'll be discussing those in a couple minutes. And I really believe that interdisciplinary care is necessary, not just for optimal oral health, but for general health as well. And the thing that the 2021 update in the Surgeon's General report provided us was this idea that we really need to integrate all of this thinking, right? That we need to integrate medical and dental providers so that we have similar messages, that we're reinforcing each other's messages. And ultimately that will lead to better penetration, better education, and better uptake of our messaging to our patients. And then focusing in more from the dental side, right? We look at our American Dental Association and some of the things that we speak about as far as prevalence of poor oral health, and recognize that 97% of our population will experience dental decay at some point in their lifetime. And dental caries is the disease process. A cavity is the resultant part of that disease. but it's the most common chronic disease of childhood. And here you can see almost half of children have had dental decay by the age of 7. And that's one of the things my group does as we go in school and do in-school health screenings, is to make sure that if we have decay experience, if we have unmet need, that we get onto that as early as we possibly can. Throughout our population, 1 in 5 adults has untreated dental disease, and we'll talk more about all of the factors that lead to that and all of the consequences that that may have. Maybe more importantly, 40% of our population has periodontal disease, which leads to infection, and we'll talk about that big part of what inflammation plays in this role of disease transmission and progression, but also with regard to pain and tooth loss. And then just on the idea of cancer, oral cancer, more than 58,000 cases are diagnosed each year. More than 12,000 deaths across our country are attributed to oral cancer. So we want to make sure, as that's one of the things we're focused on as a state, is early intervention, right? Is how we can make sure that we're teaching people how to self-screen, how to understand when it's time to go and ask a provider questions, and to make sure these diseases don't progress to the point where we're experiencing some of these negative outcomes that we're reporting on here. So some of the consequences of oral health, again, as we've been discussing, really all relate back and are exacerbated by the social determinants of health. And I think that's so important, right? Not just to recognize that we have an oral and systemic connection, but more importantly, that there are economic, social consequences of all of this. And how do we, again, as providers, kind of pool our power together to influence our patients to better understand and prioritize their oral health? And something I mentioned a few slides back was this idea of that during the pandemic, I think we really started to broaden our thought process about what is a healthy person and what constitutes overall wellness, as opposed to just physical health, dental health, mental health, societal health, whatever that might be. And you see on the left-hand side of this, the 8 kind of buckets that make up what overall wellness or overall health might be. But we should also be recognizing that mental health and oral health are very closely related. Studies show us that mental health disorders, people are far more likely to lose teeth. We also see that because of the stress, anxiety, depression, eating disorders, and everything else that can be associated with mental health conditions, how that can have such direct impact on our oral health. So what about the disconnect, right? I mean, if we can say, hey, people should access oral health, we should really talk for a couple of minutes about why some of the reasons are that people aren't necessarily pursuing oral health care. Well, first statistic here is that 33% of Americans had a medical visit, but not a dental visit in 2019. And we'll be looking for more updated statistics coming up in the next few months. But what that means to me is there's a big opportunity for a collaboration, right? No matter how loud I yell my message, a third of our patients are not going to hear that because they don't have the opportunity to have a dental visit. Then we see just about 10% of Americans had a dental visit, but not a medical visit. And there's an opportunity for us as dental providers to kind of broaden our scope, to take a look a little bit more holistically at what patient needs might be and to try to contribute in any way that we can. And I'm sure you're all familiar, but back in 2018 out in Oregon, dentists started to administer flu vaccinations routinely in the office. The thought was that during those fall months, the dentists are going to be routinely seeing their patients, and this might be an opportune time for them to introduce that conversation because they might not have a medical visit scheduled, or getting access to a flu vaccine in some other way might not be so easy. So again, this idea of cross-collaboration and medical-dental integration. But to be quite honest, many of the medical providers that I interact with lack a comfort with general basic oral health knowledge, and certainly are not expected to conduct exams, right? What we really need is to make sure that we can ask the right screening questions, maybe make sure that we have the correct information for when and how to make dental referrals. And then on the flip side, right, when we see as how dentists might limit people seeking oral health care, it's that many dentists don't have expertise or feel comfortable in providing care to very young children, to pregnant women, to patients with special health care needs. And that's always an opportunity for us to look at, again, expanding our education, continuing our education to make sure that we can offer the best care possible to our patients. So what about some of the inequities that exist currently in oral health? Well, things that we focus on, right, following up from that previous slide, is that the uninsured rate for dental insurance is 4 times higher than that of medical insurance. And much of my team who spends their time on the phone discussing with individuals how to find a dental provider, we find ourselves quite often making sure that people actually understand what benefits they have, what their eligibility consists of, and how they can access and navigate through the healthcare system in order to realize what they're entitled to. We also should understand that uninsured and publicly insured adults make up 70% of the 2.4 million emergency department visits each year for a dental problem. And that is a huge problem for all of us, right? Especially here in Delaware, we frequently realize that patients from down in Kent or Sussex County are traveling all the way up to Newcastle, to Christiana Care to seek 24-hour care for their dental problems, and often directed at an emergency room. And we certainly don't want our patients redirecting physicians' attentions from the problems that really need attention. So again, understanding what roles we can all play. Medicare offers no dental coverage for more than 37 million adults and people with disabilities that it covers. So again, while there may be some ability to help, often the older we get, the more needy we become, the less opportunity we have with regard to oral health. And also when it comes to Medicaid, it depends on where you live. Several states still have no adult dental benefits. Several offer very limited coverage or emergency only coverage, and several require copays for this care. And here in Delaware, just a couple of years ago, we finally got an adult dental benefit as part of Medicaid. And while that's an exciting step forward, the truth is it's very preventive in nature. And if we presume health of our patients rather than the fact that we need to treat existing disease before we can get to a state that they're healthy, many providers have been disappointed as they're able to diagnose a problem and a disease, but don't necessarily have the resources to be able to treat it. So a great foot in the door and a move forward for our state, but still lots of work to be done with regard to dental benefits for our Medicaid recipients. Now, when we look across the country, and here this is some statistics from the CDC regarding health disparities that were released in 2024, you can see that Mexican American children, approximately 70% of those, have had cavities in their primary or permanent teeth, compared to only 40% of non-Hispanic white children. Additionally, non-Hispanic Black children, when it comes to sealants, that preventive coating that we can put on the teeth that will either eliminate or slow down decay progression in the mouth, we see that non-Hispanic Black children have a much lower presence of sealants than non-Hispanic white children and Mexican American children. So as we start to focus in on, hey, maybe how can we help? What are the right questions that we could ask? To me, some of these statistics are very important as it kind of provides us some of the guidance and lanes that we should be operating in. When it comes to uninsured working age adults, untreated decay is about twice as common for those with no health insurance as for those who have private health insurance. And you can also see that non-Hispanic Black working age adults have a prevalence of untreated decay that is twice as high as non-Hispanic Black adults. So a lot, for non-Hispanic white adults. So again, a lot going on, but we can really focus in on some of our high risk and targeted populations for us as a public health bureau to provide them the information that is most likely going to have benefit for them, to most likely influence the way they look at and prioritize their oral health. So as we kind of move on and continue through some of the national landscape and now focus in a little bit more on Delaware, Delaware has a very unique landscape when it comes in regard to dentistry. First off, we should recognize that roughly 1/5 of our population live in a dental shortage area. And what you see on the right-hand side, to me, is one of my favorite maps or depictions of population in our state. It's basically a bar graph or a heat map showing you where people live. And we all recognize how populated and how densely populated Newcastle County is. But this really kind of shows to me how sparsely populated Kent and especially Western Sussex County actually are. And that really puts in our frame, right, the importance of getting providers into those areas. It's not just about adding more providers into the state, but putting providers where they need them the most. And all of Kent and Sussex County, and I believe a good part of Newcastle, if not all of Newcastle County, has recently been recategorized as health provider shortage areas. And when it comes to with regard to provider population ratio, Delaware has the least favorable ratio of providers to population in the country. So there's roughly 400 or 450 or so providers, depending on where you look statistically, for almost 1 million people in our state. So when people say to me, hey, it's hard to find a dentist, I often say, right, kind of tongue in cheek, that it should be when you understand that we have the least favorable provider to population ratio. What that means for us as a dental patient, it's going to be difficult to find and access those providers. So some of the things we've worked on in public health is we've looked on creating legislation to change dental access. And a couple of years ago, we had a licensing change, which afforded federally qualified health centers to hire providers that were previously licensed in other states with fewer regulations than previously existed. And in 2023, we had a great public health intervention in that we are now required, Department of Education is required to provide an oral health screening to all students in public and private and public and charter schools in kindergarten in our state. And that's so important as our group is facilitating that, to understand what a baseline level of health is for the child, right? We want to make sure we have healthy children in school so that they can learn. So one way is by adding more providers. Another way is to start to be creative with the way we can access and provide information and opportunity to the patients within our state. So now some of the things that we should be considering right here in Delaware, things that we can focus on that might spark your interest as a provider to seek more information out or to help guide patients to good information. So we take a look at our water systems and understand that an increasing percent of our population is served by non-fluoridated water. Now, also, many people drink bottled water as opposed to tap water, and also well water is non-fluoridated. So when we consider the decrease in people who have access to fluoridated water, the fact that we're drinking bottled and water quite regularly means that we're having less exposure to fluoride. And fluoride is a mineral that helps to work to remineralize the enamel in our teeth. So a very important part, and we'll discuss more about how pH impacts our mouth, how biological transmission is important in what we do. But one of the things that's important for us is the idea that we want to reintroduce mineral content into the tooth, and fluoride is a great way for us to do that. Now, another statistic that to me is very interesting is we look at the number of adults that have had a dental visit. And here you can see that education plays a huge role, right, in the percent of people that seek out a dental visit. And why this is so important is because we want to practice preventistry, right, not dentistry. We want to work to prevent problems from happening rather than treat and restore things that already occur. And we're far less advanced than European countries when it comes to preventive therapeutics. And I think that often comes to the fact that people don't have access to providers or aren't given the right information leading up to their visit, so they can be seeking out these treatments so that, again, we can prevent rather than restore whenever possible. So another consideration is looking at how adults with less than a high school education are more likely to experience tooth loss. And tooth loss is a very important part, and you can see on the right-hand side that breakdown between different degree levels and whether or not people have lost teeth. But when we start to lose a single tooth, it has this very, very predictable cascade of what happens, from tooth super erupting to invade other spaces or vacant spaces in the mouth, other teeth becoming more mobile in the surrounding areas, bone remodeling over time in an unfavorable way for the patient. And it all comes down to this idea that we want to save teeth as much as possible. So for me, that idea that we really are focusing not just on what it means to lose a tooth, but who's losing teeth, right? And how we can start to influence through education to make people understand the importance of retaining their teeth and what starts to happen once we lose a tooth. Here again, another breakdown, as you can see, 68 adults age 65 or older that have lost 6 or more teeth. And that's a considerable amount of teeth, right? Most of the time people are losing posterior or back teeth. And again, that changes with bony support. It changes facial structure and architecture, and ultimately limits our restorative potential in the future. Because if we don't have the bone, we don't have the structure, we don't have the support to do the things we've liked to do, it rules patients out for certain treatments that they might otherwise be very excited to receive. And here's an example, again, looking at statistics of losing teeth on the right, but of what can happen. And you can see the facial profile of someone with or without anterior teeth. And again, it changes the whole complexity of the face, right? The whole way muscles interact. And one thing I've always told my patients are to understand that dentures are not a replacement for your teeth. They are an alternative to not having teeth. And that to me helps level set expectations, because I can't reproduce what was once naturally there, but then I can give you the best artificial reproduction of that possible, so that we can improve your ability to chew, improve your perception of yourself, both from a social and aesthetic standpoint, and allow you to do all the things that you would like to do. So now that we've talked and kind of set frame both on a definition of what oral health looks like on a national and state level of some of the considerations that we are dealing with, we should really talk about some of the relationships that we know exist between oral and systemic health. And certainly this role, or the role of inflammation, and you all are probably far more advanced in your knowledge of how the inflammation process works, right? What the biological interactions and reactions are to certain stages. But what we have to understand without a doubt is that inflammation plays an increasingly recognized role in oral and systemic interaction. And here you can see, if you just Google oral systemic health, you'll come up with 1,000 visuals that look very similar to this. But we should realize, again, that inflammation constitutes a major mechanism for this link between oral disease and systemic health, specifically with regard to periodontitis. And it's all about the bacteria, right, that causes this infection, that results in this inflammation, and ultimately enters to our bloodstream, that can lead to the laundry list, right, of health consequences that we see on the right-hand side of this photograph. From influence to stroke, Alzheimer's disease, heart disease, preterm or low birth weight babies, and maybe most publicized in today's day and age is this idea of the relationship with uncontrolled diabetes and the causative relationship, a two-way effect that this can actually have. So very focused in, because most people, when they look at even our patients, when we discuss periodontal disease with them, it's one of those things where, hey, if I can't see it and I can't feel it, I'm not sure that I want to treat it. So we really need to focus in on educating, on making sure people understand what the progression of this disease means, and that by the time you can see and feel it, it's often too late, right? I can't put back tissue, I can't put back bone. So we have to make sure, again, as both medical and dental providers, that we're showing our patients that there are two-way relationships here, and it's important for them to pursue not only physical health, but oral health as well. So now I'm sure you all can recognize that the picture on the right-hand side is a tooth that has dental decay. The picture on the more left-hand side of that is a normal or healthy tooth. And one of the things that people don't frequently realize is the time progression that it takes in order to get from that left-hand side to that right-hand side. And we're looking at years, right? Not 1 or 2, but likely 3, 4, 5 years or longer. So very thankfully, decay progresses very slowly in a patient's mouth. We will often, offer therapeutics that can reverse early stages of decay, again, through mineral content and things like that. But it gives the patient a long opportunity before they see very negative consequences of dental decay. But by the time we get to the right-hand side, we have very costly restorations, very time extensive, and oftentimes don't have the best long-term prognosis. And what that leads to is often patients making decisions, right? Weighing out, well, hey, the time, the money, and the prognosis versus just taking the tooth out. Well, hey, let's just go ahead and take the tooth out. But that's non-reversible, right? Once we do that, we've now again moved down this pathway where we should expect other negative things to happen. But this disease progression, again, is thankfully very slow. So let's talk just a bit about disease transmission. So the disease itself is caries, right, which we refer to as tooth decay, but that's a vertically transmitted infectious disease. It's very, very frequently from mother to child, where we introduce the decay-causing bacteria into a patient's mouth. The term or our familiarity with the bacteria Strep mutans is what's responsible for dental decay, and it's the bacteria that's contagious. This bacteria causes cavities by metabolizing sugars into acid, and that's going to demineralize the dental enamel. And then the way all this relates back to patient diet is not just understanding that, but that poor dietary habits are going to keep sugar in the mouth in between meals and basically allow this bacteria to continually feed. And there are some great visuals for this, but I found even with my two young children, I have a 13-year-old and a 7-year-old at home, that when we're in that book reading phase at night, right before we go to bed, there's some really neat things that introduce to children. One of my favorite books is called Sugar Bug Doug. And it's this idea that, hey, we need to get those bugs out of our mouth. This is within our control. So it's not just about putting a brush in your mouth, but effective brushing, supervised brushing for those that are young. And these are things very easily that we can reinforce messaging with as a physician, right? To encourage parents to make sure that they understand resources are out there and ways that they can help influence the oral health of their children. And as physicians, you're so geared towards understanding disease transmission, how to move from one thing to another. I thought this was really a great visual that was produced by the DentaQuest Institute a couple of years back, showing this idea that, hey, what causes demineralization can be reversed, right? If an acidic pH in the mouth is going to cause enamel to demineralize, what can we do to elevate that pH? If we have an acidic environment, how can we create a neutral environment? And this quite often, right, we have to understand the way we all take in and learn information kind of falls very in line with, I think, the way most of the diagnostics are done with medicine. So here to show you a few examples, right? Things that go on that are happening throughout life is that when the tooth pulp, and the nerve is called the pulp, becomes necrotic, infection can spread and become potentially life-threatening, right? And untreated oral bacterial infections can cause intraoral abscesses, and you can see that on the picture on the left-hand side of the screen. Sinusitis, facial and periorbital swellings, right, that you see more in the middle, a brain abscess, airway compromise, and you can see on the right-hand side of the screen how difficult of a situation it might be to treat this patient. Never mind just the physical part of retrieving or getting the tooth out, but also to gain anesthesia on a patient like this, right? It's often very uncomfortable both for the patient and the provider in these situations. So getting at things early, again, is the key. Now, two things we often refer to are stories that unfortunately have tragic outcomes or had tragic outcomes, but can really clue us into what can get a parent to absorb a message. And the story of Diamante Driver, a 12-year-old boy who lived in Maryland, right, a neighboring state, who had a long-standing never complained about a long-standing infection. He did have a medical home, right, but no dental home. Unfortunately, the mom couldn't find a provider, and ultimately Diamante passed away due to a dental infection. And we never want to lose another 12-year-old boy to a dental infection, right? So that's not to posterize what happened, but to really lend towards making sure people understand the severity of this. And it's not just a little tooth, but if unchecked, can have catastrophic results. And one that made national news in 2017 was hear from someone who had recently immigrated to our country, a 26-year-old truck driver who was going cross-country from California to New York. During that trip, he had actually stopped somewhere in the middle of our country and sought out a dentist because he was having pain. But unfortunately, the antibiotics didn't take effect quickly enough. By the time he got to New York, he was hospitalized and passed away, and he left behind a wife and 2 young children. And that to us, right, when we put a face and name to some of these stories, it really brings in a perspective that, hey, I don't want that to be me, my neighbor, or anyone else I know. Let's make sure we have good information out there and avoid catastrophes like this from ever happening again. Now, other things we might see or recognize should be that people with tobacco use disorders are at higher risk for oral cancers and periodontal disease. And in that top right photograph, you can see an image of what periodontal disease very frequently looks like. People who have alcohol use disorders can have a higher incidence of oral cancer, and there you can see a lesion on the right side of that patient's tongue. Also, people with substance use disorders especially methamphetamine use, can suffer not only due to dry mouth, but also tend to snack and drink very sugary drinks, right? But this is what we would categorize very routinely as meth mouth, or something that we see complete destruction of the patient's oral cavity. And most of the times we see these patients are very young, the teeth are non-restorable, and unfortunately they're committed to being edentulous at a very young age in their life. And now beyond this, right, this idea that infectious disease can often manifest itself orally. So we'll see things early on that can be triggers to make sure we understand that something very much more significant is going on systemically. And here you can see that, whether it's candidiasis, oral hairy leukoplakia, Kaposi sarcoma, and one of the more common pieces, ANUG, right? You see this gingival hyperplasia, this inflamed situation, very painful for the patient, very difficult for us to remedy in the office. And all of this, again, comes from systemic complication. One piece that people often don't recognize connections with are how connected HPV viruses are to cancer, and that 25% of oral cancers and 2/3 of oropharyngeal cancers are related to HPV-16. So my group spends a considerable amount of time with education. We do HPV vaccination programs, right? Things you might not think are dentist related, but the reality is we need to make sure that our patients are well educated about what can negatively cause oral health issues. So now that we've spent the first half of this really discussing and understanding some of our problem, what are some of the things that we do to make progress here, or to start to solve some of these oral health issues that we see? Well, we take guidance as a public health group on a national level and focus on goals set forth by Healthy People 2030. And here you can see that the goal is to improve oral health by increasing access to healthcare, including preventive services. And the ways we want to go about this is to increase awareness of the importance of oral health and its connection to overall health and well-being, to increase acceptance and adoption of effective preventive interventions, right? So gear people towards the preventistry part of it all, and reduce the disparities that we've already discussed, right? To make sure that we can get everyone equally healthy across all of our population bases nationally. But hey, this is one of those things that it's easy to say and hard to do. We should recognize that as healthcare providers, we all have very similar challenges, and that we have increasing demands on very limited time. We can often forget to ask about oral health issues when other problems compete for attention. And again, things that my staff reports back to me all the time as they converse with patients, it's very difficult to prioritize an oral health visit when there are housing insecurities, food insecurities, and so many other problems that outweigh oral health. And again, until we recognize that this will lead to further and further problems, it's hard to shift focus to getting oral health care. whether it's an electronic medical record or your electronic health records. But I hear from physicians that oral health prompts aren't often incorporated into all of their systems. Now, I know for me, it's one of the things I always smile when I'm asked with my physician is, have you been to the dentist? And that's a great question to ask, but it only kind of is the tip of the iceberg, right? The follow-up needs to be whether or not I've been there. Am I experiencing any oral pain? Do I have any conditions that require care or any unmet needs? But just telling you whether or not I've gone to a dentist is nice that we've got a screening question, but it really doesn't get to what you as healthcare providers can provide into the equation, which is helping to assess whether there's an actual unmet need for the patient. And then the idea that we all have, or physicians have very limited oral health training, right? We can be unsure of the correct questions to ask, but this is where understanding how to best collaborate, right? Again, across the board, medical dental integration, and what providers locally serve as your best referral base, right? We should never be shy about asking one another questions. So what are those common ways that we should be interacting, right? Physician and dental interaction. Well, certainly referring for routine and emergency care, and the idea of pain management, right? This is something that as we look at causes and understanding what some of the causes can be, we should be conversing far more frequently about pain management, medically compromised patients. Dentists often ask for permission, right? And I'll use that in my air quotes with regard to anticoagulation medications when it comes to tooth extraction, periodontal surgeries, and implant placement surgeries. So this is something we're very reliant on our physician friends, right, to help make sure that we understand what is the right way to approach the condition that the patient may have. And in general, I would say dentists have a tendency to overprescribe antibiotics. So certainly making our patients more and more aware of when antibiotics are required so that we can prevent that growing antimicrobial resistance that we see going on around the country now, making it harder and harder to treat infections when the patient actually does need an antibiotic. So hopefully all of you are collaborating with your dental professionals in the list of ways that we've already outlined here. Now, some of the things for us that really factor into our conversations with patients is understanding about how frequent ingestion of sugary snacks and beverages contributes to obesity, diabetes, and dental decay. And I'm a big believer in visuals, right? And I'll show you a couple in a few minutes that matter a lot to me. But that recognizing that once we have dental pain, once we have problems chewing, that makes eating good and healthy food even more and more challenging. Again, how do we eat an apple if our teeth are mobile? How do we chew a steak if we constantly have pain in our mouth? And other things that we often think that we're doing good and don't realize the bad in is that, especially with children and patients with special healthcare needs, the way that they frequently snack or are rewarded for good behavior is very troubling. As we do in-school screenings, we frequently see children with special healthcare needs being given a sugary snack as an okay for having completed a task correctly, followed instruction appropriately. And that's just so heartbreaking, right? Because not only is this child have so many other challenges that they need to face, but we're actually feeding, pun fully intended, a problem for happening in their mouth. So oral health should be the least of concerns for these people. So we want to get them on good snacking regimens, right? So as physicians, we can always mention to a parent, hey, what type of snacks are we giving in schools? And maybe that we can guide towards better options rather than just the things that tend to be the easy go-tos, which are the gummy bears and, you know, the sugary, high tasty, really enjoyable stuff for the kids. So a couple of visuals that I love, and I put up things like the American Heart Association decal because these are visuals that I pull off a website. So there are tons of resources that are available, but a couple of visuals even correctly placed around an office or waiting room can lead to some great conversations. And this is always one I love, right? That understanding of how much of a drink is actually composed of sugar. And when we realized that we far exceed, right, our recommended daily intake with like half a bottle of Coca-Cola or Sprite or root beer or whatever our favorite beverage might be. So water, certainly always the best of opportunity. And one of the things I will tell people, because I hate to tell people, don't drink the soda that you like, don't eat the snacks that you like, because when I tell you things you don't want to hear, you're less likely to listen to me. So one of my messages is, if you are going to do those things, just get yourself over to a water fountain or to a tap and just swish some water around your mouth and spit it out. Do something to help change that very acidic, very sugary pH that we've now created in the mouth. And let's do something to neutralize it or to create a more acid resistant environment in your mouth. And a great visual or handout from Colgate you can see on the right, talking about some good steps for oral care. And we recognize that a medical home is a great place for screening and guidance to occur. We aren't asking anyone to do oral examinations, but certainly if you aren't familiar with the Smiles for Life courses, as a medical provider, it's a great series of information which gives you great anticipatory guidance regarding caries, oral health promotion, how to make timely referrals, how to look at fluoride and fluoride varnish treatments for your patients. So again, terrific resources out there. My goal in any talk like this is to kind of spark interest, right? So that as professionals, we go out and read more on areas we know we're lacking knowledge. So hopefully some of these things are hitting home for you, getting you to be more interested and involved in what can happen. So what can we expect from our medical providers? Well, certainly counsel on oral health promotion, right? We can do some screening, whether it's through some questions or even a quick visual into the mouth, and we're going to finish in just a couple minutes with doing one of those together. That idea that we can focus on prenatal oral health, right? Start as early as possible. Also, as physicians, if you're collaborating with schools, with Head Start programs, with other providers, to make sure that oral health is included in that, right? And especially in large-scale community events, we love it when we get invited to health fairs and other things that happen, because we know we get huge exposure to large groups of patients and can get our information out there as much as possible. But also one of the key things, whether it's you as the provider or your office staff, is to make sure we're very familiar with who accepts Medicaid, whether in our area, whether we're familiar with referrals to the federally qualified healthcare centers that may offer dental services like Lared and Milford and out in Georgetown, right? So the familiarity, right, helps us to continually connect the dots and guide people towards the resources that we need. So if we're going to educate people on the nature of disease, understand what pH level contributes to this equation, make appropriate referrals, and identify providers who are going to collaborate to integrate this care, let's talk about that for a couple of seconds. So if you're doing caries risk assessment, I would guide you towards the American Academy of Pediatrics paper. It talks about CAMBRA, which is caries management by risk assessment. And the important part about that, as we show some of the detail on these forms, is the idea that there are social and societal factors that determine whether or not someone is at high risk, right? It's just not whether or not your mom had decay or whether or not you like sugary snacks, but some of the things that go along with that, whether you have socioeconomic issues, whether you live in certain proximities to providers. So just good visuals, right? Good information to help spark interest again, if you are looking more and more into these things in your practice and patient education. And as putting fluoride varnish into a patient is something that medical providers can be reimbursed for. If you're not doing that, I would encourage you to take a quick visual, take a look at a video if you just YouTube fluoride varnish application. But when I was first asked the question years back in public health, do you think medical providers should put fluoride varnish on? I thought absolutely, because we're better as a team. And how would you train them to do that was the follow-up question. And my response was that in 5 minutes, I could train a concerned mother, never mind someone as educated as a physician, right? Here, I mean, if we read the instructions in 30 seconds, watch a visual 1-minute application video, we are absolutely ready to go. So if it had been something that you've been looked at but been intimidated by, certainly I would encourage you to continue to look or to ask questions as we wrap up in the next couple minutes. So things that we want to make sure that we're reinforcing: how to maintain a good oral pH, how to reduce levels of bad bacteria in the mouth, and how to practice effective home care. So what that looks like, right? And here I've just got a little outline so that we never forget to include our caregivers in these conversations, right? Caregivers often are overwhelmed with some of the needs and don't really understand the importance of how oral health can fit in there. We recognize that with elderly and medically compromised patients, just the manual dexterity is often a challenge to be able to brush effectively. So we're frequently modifying devices, brushes, adding different things to the handle to allow someone to work more comfortably. But the caregivers are also a very important part of this equation, right? To make sure that they have the right information and understand the importance of oral health. So now the role of pH, right? So understand that the prolonged periods of very low acidic environments, and for us, that's a pH of below 5.5, is going to be responsible for demineralization and net mineral loss in the tooth. So what we want is a calcium phosphate exchange. As calcium and phosphate go out of the tooth, remineralization will happen as it comes back in. So we can prescribe higher levels of fluoride in toothpaste. We have other pastes that we can use for the patient at home, but it's about understanding what risks they're putting themselves at and what interest they have in compliance to some of these alternate techniques. So that process is that eating and drinking is going to lower pH. Saliva is designed to restore that pH to a natural, healthy, or alkaline level. So the way that balances out is once we drink something, the pH drops, mineral is lost, saliva comes in, pH recovers, mineral returns. But when we get that out of balance and we have prolonged periods of demineralization, we can wind up with decay happening. So again, as you see on the bottom, there are oral rinses, sprays, gels, lots of things we can use, but we have to understand, and the patient has to understand, what the cause and effect of diet is in their mouth. So bridging the gap, we're going to talk about as a bureau, as a public health entity, how we increase access to care through referrals, as we increase oral health literacy and educate our patients so that they make better decisions about their oral health. And as we continually reach out into the community, we ask our physician partners to do all of these things with us. So some quick guidance as we wrap up. If we're talking with prenatal patients, would be that snacking, nausea, hormonal changes are a natural part of pregnancy and can make you particularly vulnerable to disease. And if left untreated, severe gum disease can increase health risks for mother and baby. We're generally safe in that middle trimester where we're comfortable doing dentistry of any kind there. We like to avoid anesthetics later in the third trimester. And people have always had a hesitancy in the first trimester, but there isn't much evidence to suggest that someone shouldn't pursue dental care even early on in their pregnancy. And good advice, like around morning sickness, is rinsing your mouth with a teaspoon of baking soda and water after you vomit, helping remove harmful acids, and then brush your teeth. We don't want those harmful acids on your teeth and you brush them in. You've got to rinse and clean that out before we go through a preventive therapy. And what about a first visit to a dental provider? Well, I hope you'd all recognize that we all talk about age 1 dental visits. And what we're trying to accomplish is establishing familiarity and trust, helping prioritize the importance of oral health, working to identify developmental issues to provide early on counseling, and most importantly, as we want to have every patient to have a medical home, to help establish a dental home for them as well. But one of our biggest challenges, quite openly, is we hear from people all the time that they call a dental office and make an age 1 appointment, and the dentist tells them if the child isn't having a problem, come back in a year or 2, right? But what we really want to do is continually reinforce that message that even in a quick knee-to-knee exam, quick visual inspection, it's working to set good habits, familiarity and trust, and age 1 visits should absolutely be a priority for our patients. Now, for children, we should talk about wiping gums before we have teeth, using a clean washcloth both morning and night, using soft bristle toothbrushes, right? Something that's changed through the years. My dad always believed that the harder bristle, the better, right? But we need to change what some people believe is true. Whether it comes down to different ethnic preferences, but we often see people putting juices or milk into bottles as people sleep. So only formula, milk or water in a baby bottle, right? No juice or sweet drinks. Not sharing spoons, forks, anything that could transmit bacteria from one person or another. And that we first start to look for dental sealants around age 6. When you first get a permanent first molar in the mouth, that becomes the time as providers we start to look to be more aggressive with preventive therapies so that we don't see dental decay developing on permanent teeth. And just good guidance, whether it's to a patient or to ourselves, is that we want to look at brushing teeth 2 minutes each day, 2 times a day, and use a timer, right? It's crazy what people's perception of 2 minutes is versus what the reality of 2 minutes is. But flossing, regular dental visits, ideally every 6 months, but in reality, I'm probably more of a every 7 or 7.5 month kind of person based on my schedule. So it's not a perfect formula of 2 times every year, but it's just that idea to get into a routine. Understand that we should be exposed to fluoridated water if we're drinking bottled water or well water, that we need exposure to fluoride in other ways. And certainly as a dentist or physician, we can write for fluoride prescription, write tablets if it's so needed, although that's very few and far between, but that stuff is out there and exists. So in the last minute here, let's just do a quick screening together, something that I'd be looking at if you ever had interest in looking or are looking in patients' mouths, that I can help guide you through some of what you see. Well, what we really want to establish is whether there's an urgent situation, if there's any unmet need, or if there's prior history of treatment. So what you see on the left-hand side in the back is untreated decay, kind of that brownish yellow lesion. We often describe that to the touch as feeling leathery. If we were going to use an instrument, we could kind of scrape and pull, almost as if it would feel like if you took your fingernail and scraped that along a leather coat. And that's far different in texture or in toughness to what the natural tooth enamel looks like. Now you also see untreated decay in the front part of the mouth. On the left-hand side, I've got arrows pointing to an area that talks about arrested decay. And while we haven't talked about that at all during this session, there is a drug called silver diamine fluoride, which is applied topically to a tooth. It's fairly new in acceptance in the United States, less than a decade or so, but it's been used in Japan for almost 100 years. It actually stops decay in its tracks. The only downside is it discolors the tooth black, as you see on that screen. So we want to make patients aware of that, but if they don't have access, if they live in very rural areas, right, these are our best opportunities not to allow the disease to progress. And we also can see and identify a filling on the right-hand side towards the back. And why that's important is it shows us that the person has been susceptible to caries, right, to the disease of dental decay. And that gives us good insight into how we might guide that person, whether it's from a dietary standpoint, with preventive, how they brush and floss, but gives us insight into what the patient has experienced. So if you were going to do this, one thing I would encourage you would be to look in the mouth with a black light flashlight, because UV light interacts with enamel and the restorative materials we use with dentistry very differently than natural or ambient light. And here you can just see a quick picture on the top as the common materials that we're using over here, a shade guide with how we would match to natural teeth. But when shined on black light, you can see that these are all actually filled with these filling materials, and you wouldn't be able to see that under natural light. And what this will show you, if you're doing this in an office as a physician, you will also see exposure of bacteria or calculus or plaque or whatever our terminology for that might be. But we will see a very obvious, and this allows us, even with patients, to hand them a mirror to allow them to see what's happening. So you can tell me that you're brushing, but are you brushing effectively is far more important. And there is a difference, again, for yourselves. You would see this all during Smile for Life courses, but teeth can very naturally stain, like you see on the left-hand side. We wouldn't do anything in situations like that. But on the right, you can see there's kind of a break in the tooth structure where these arrows are pointing and some shadowing underneath there. If I were to shine my trusty black light on there, it would even further highlight how extensive that decay was. And we already mentioned, and here you can see a tooth that has extensive decay in the outline of that, but our black light will show us what the restorative material content in that tooth is. So again, helping to understand progression of the disease, what the patient has been exposed to in the past, and what the prognosis for those teeth are in the future. Here's an infection that you can see on the left-hand side, some decay that you can see on the right, and all of this content would be included in a Smiles for Life program. So that's it for me, guys. I know I ran right back to the top of the hour, but I'd like to leave you or open it up for questions with just this, that we do have free resources and education available within the Division of Public Health. My group, the Bureau of Oral Health and Dental Services, has a hotline number, which is 302-318-8850. Patients can call in. We will help them navigate to the appropriate resources that they need. Online, we can find dental resource guides that help them, patients, to find providers, navigate towards them, understand benefit eligibility, and that guide is available in English, Spanish, Chinese, and Haitian Creole. And if any of that is too much to remember, I would encourage you just to remember Google Delaware Oral Health Program or Delaware Bureau of Oral Health, and it will take you to our resource page where you'll be able to find any of this information or far more extensive information about oral health and the work that we do in the community. So I thank you all. I realize, again, you've given me your lunch hour. I hope I've provided some decent information for you and sparked some professional interest on the importance of oral health and how we can best prioritize that with our patients. So I would love to open it up if there are any questions or anything else we can do.
Thank you so much, Dr. Conte. That was excellent. I wish I had known some of this information 20 years ago when my kids were young, but yes, excellent information. So questions for Dr. Conte. I see in the chat, Song is saying that as a refugee, she sees the disparities in the need for oral health education among the refugee population. That's a very good point, and one that I think we will share with our refugee program even as we kick that off in the next few weeks.
Sure.
Anyone else? Questions for Dr. Conte? Yeah, I will tell you, Dr. Conte, and this might just be my ignorance, but I did not know that dental caries were transmissible. So that is just one of many new things I learned today. So thank you.
Yep, that bacteria is absolutely transmissible. So.
All right.
Lynn Robinson, I'll just say that what a excellent presentation, Dr. Conte. Really learned a lot myself. With your permission, the Medical Society of Delaware will share your slides and a recording of your presentation on our website.
Absolutely.
Okay, great. And I'll just note that everyone attending today will receive an email from Ansha Arnold for CME to claim your CME with instructions. So I'll just note that as well. Thank you so much.
Thank you.
All right. If there are no questions, going. I know it's it's a little bit over, but thank you all for joining us today. This was a great presentation, and it was nice to see you all. Enjoy the rest of your day.
Thank you, everyone.
Thank you.